Good morning, everybody. I greet you warmly. My name is Garus Pakowska and I am an epidemiologist and academic teacher at the Department of Nutrition and Epidemiology of the Medical University of Łódź in Poland. Today I will tell you about sharp injuries among nurses, among healthcare workers. I will talk about our current research as well as my thoughts regarding recommendations on what to do to make it better. Presentation consists of the following thematic parts: definition of occupational exposure and regulations, epidemiology of sharp injuries among medical staff, importance of training, safety devices, conclusions and recommendations. Sharp injuries are a well-known risk in the healthcare personnel, especially among nurses. Sharps contaminated with an infected patient's blood can transmit more than 20 diseases, including hepatitis B, hepatitis C, and human immunodeficiency virus, etc. Because of this transmission risk, sharp injuries can cause worry and stress to the many thousands who receive them. What is a needle stick or sharps injury? In other words, will every injury be a risk factor? Of course not. A cut, lacerations, puncture or scratch caused by a clean needle or sharp object, one that hasn't been used to inject a healthcare patient, is not a needle stick injury. To be treated as a needle stick case, the needle or other sharp object must have been used firstly in or on another person's body or in contact with potentially infectious material before the wounding of the healthcare worker occurred. Occupational Safety and Health Administration mandates the recording of work-related needle stick injuries and cuts from sharp objects contaminated with another person's blood or other potentially infectious material. Employers are legally required to maintain records of sharp injuries and provide a safe working environment for their employees. So the rule requires employers to maintain a log for all needle stick and sharp injuries. But as with all registers, in order for something to be registered, it must first be reported. In Poland, our experience is that all hospitals keep records of injuries, just as all employers keep records of accidents at work. Legally, acute injuries are accidents at work, but, back to the topic, keeping a register will only be possible if the staff reports cases of injuries. Is that so? I will tell you in a moment. In Europe, the directive of European Union is in force. The directive implements the Framework Agreement on Prevention from Sharp Injuries in the Hospital and Healthcare Sector, signed by the European social partners. The purpose of the directive is to implement the Framework Agreement so as to prevent workers' injuries caused by all medical sharps, to protect workers at risk, to set up an integrated approach establishing policies in risk assessment, risk prevention, training, information, awareness raising and monitoring. But to protect the worker from risk, we need to know the risk. So we go back to reporting sharp injuries. Despite the risk, sharp injuries are often underreported, leading to a lack of awareness and preventive measures. Is it true? In our study, we asked if the respondents reported the latest incident of sharp injury. Only almost 55% of the total number of respondents answered yes. But we have to emphasize that the other half of incidents haven't been reported anywhere. In our new, yet unpublished study, conducted only among nurses, we have shown that non-reporting is still a very, very important problem. A few years have passed and not much has changed. Fewer than half of the nurses immediately reported sharp injuries to the person responsible for post-exposure prophylaxis at the workplace, and 42% of nurses didn't report the injury incident to anyone for various reasons. The most common of them are: I didn't report injuries because nothing results from these reports. No, because I didn't see any threat. No, because I didn't know to whom I should report such an incident. Failure to report is not just a problem for Polish workers. It occurs all over the world. Underreporting was found in 58% healthcare workers in Saudi Arabia. No reports were received by 46% of employees in Israel, 28.5% in China, 27% in Switzerland, and 60% among USA students and 29% among USA nurses. And in this USA study, the three most common reasons for not reporting sharp injuries included healthcare workers perceiving low infection risk based on patient medical history, fear of peer perception, and belief of lack of reporting utility. It is estimated that each year more than 1 million healthcare workers in Europe and 385,000 healthcare workers in the USA experience injuries resulting from accidents involving needles or sharp instruments. According to estimates in healthcare facilities in Poland, there are approximately 100 injuries related to the use of medical equipment by healthcare workers daily. That's around 37,000 injuries per year. In one of our studies, we estimated the annual number of injuries in hospitals. That was the analysis of injury registers on the basis of 252 hospitals in Poland. In the study period, that was 5 years, almost 10,000 sharp injuries were registered. Majority of the sharp injuries were recorded among nurses. The needle was the tool responsible for the greatest number of the sharp injuries in all professional groups. The average annual injury rates were 16 per 1,000 doctors, 20.5 among nurses, and 16.8 among per 1,000 paramedics. And based on the data on non-reporting assessed from the same study, we estimated that there are probably above than 13,000 sharp injuries every year among hospital care workers in Poland. To this should be added healthcare workers working in other healthcare sectors. Now a few words about the structure of injuries. These are the results that are waiting to be published. Half of the nurses declared contact with blood or other potentially infectious material at least several times a day. The most frequent contact with body fluids was experienced by staff working in a hospital, in particular in surgical departments. What's more, in our study, nurses from large cities declared statistically significant, more common contact with potentially infectious material, and also seniority was related to the frequency of contact with potentially infectious material. Respondents with longer experience more often indicated increased contact with infectious material. In the same study, we assess the frequency of sharp injuries among nurses. The table presents characteristics of sharp injuries in the study group. The frequency of injuries differed among nurses with different seniority and in different workplaces. At the same time, no relationship was found between the frequency of injuries and the type of treatment among nurses working in hospitals. Only 1 in 5 nurses had never experienced sharp injuries. The wound structure we analyzed on the basis of information about the last injury incident remembered by the nurse. Why so? We assumed that the study group would include nurses who had hurt themselves several times. And to be more precise, we asked about the most recent injury, so that they would not choose just any one of many several injuries, so that they would focus on the most recent event. A vast majority of respondents declared that sharp injuries concerned a finger and were caused by using an injection needle. Activities during which the injury occurred were mainly blood sampling, although several nurses were injured while putting the needle cover on. This should no longer be happening for many years because procedures prohibit recapping the needle. In our new study, data presented in the table 5, ampoules and conventional hollow bore needles caused the most injuries. Nurses indicated unpredictable behavior of the patient as the most common cause of injury. This has been the most common cause for many years. We can't avoid it, but we can train staff. We can also introduce psychological training to make nurses more resistant to stress. And what's more staff would reduce overwork. Studies from many countries have shown that the use of needles with safety engineered protection mechanism was associated with a significantly lower sharp injuries rate. According to the definition, the safety engineered device is a blade or needle used for collecting body fluids, gaining access to veins or arteries, administering medications and other fluids with a built-in safety mechanism that effectively reduces the risk of exposure. The Centers for Disease Control and Prevention estimates that 62 to 88% of sharp injuries can be prevented simply by using safer medical devices. These are devices equipped with various security mechanisms, active and passive, and both types create less risky situations, which also was also confirmed by our observations. Injuries were much less common when safe tools were used. This is a continuation of the table I showed you 4 slides earlier. We found that the expected injury rate of safety engineered devices was relatively low, below 0.1, and this risk was lower than for traditional tools. Both legal regulations and the availability of safe medical equipment are intended to protect staff against the risk. But new problems are also emerging, and now I would like to tell you something about them. In our study, most of the nurses confirmed availability of safety devices. Every fourth nurse stated that they didn't willingly use safety devices, and every fifth that they did, but they chose traditional medical tools whenever possible. The answer didn't depend on seniority, the place of work, and of the department. However, training influenced the use of safety equipment. Nurses who confirmed that training in the use of safety devices took place at work were more likely to use the devices and more often answered that such devices are comfortable and guarantee their safety. In addition, half of nurses stated that staff didn't have much influence of the type of medical sharp instruments delivered. The management didn't control purchased safety devices quality, nor did it take into account staff's opinion on the equipment. The cheapest equipment was chosen. To sum up my speech, underreporting hinders the implementation of safety protocols, putting healthcare workers at continued risk. Therefore, promptly document the details of injury, including the nature of the sharp objects and the circumstances of the incident. We have shown that changing laws and regulation is not enough. Employers should provide comprehensive training on the reporting procedures for sharp injuries, emphasizing the importance of immediate and accurate reporting. In our study, nurses who participated in occupational infection prevention training more frequently reported injuries. Participation in post-exposure training had no effect on sharp injuries reporting, but the training duration did. Nurses who had participated in such training within the last year were more likely to report acute incidents. Cultivate a workplace environment that encourages open reporting of sharp injuries, free from stigma or fear of repercussions. Reporting sharp injuries is crucial for public health surveillance and the prevention of occupational infections. What should be done to improve reporting? Offering post-exposure care, investigating the incidents, providing sharp injuries prevention training. Thank you for your attention and for the opportunity to talk about our experience with sharp injuries. Thank you very much.